Learn about rationalization of antibiotic therapy. What are the goals of antimicrobial therapy? A clinician treating a patient should employ the principles of antimicrobial dosage. Mind me, to try to irrigate the microbial pathogen from the site of infection. However, irrigation of the pathogen does not necessarily ensure the patient will be cured. For instance, in sepsis and septic shock, patient inflammatory response can play a vital role in different outcome of infection. In severe infection, the inflammatory processes drive the organ disinfections and potentially pathogen death. For this reason, early initiation of appropriate antimicrobials is essential to reduce the bacterial burden which drives the inflammation. The antibiotic selection should be based on the basis of spectrum, tissue penetration, safety profile, and it says spectrum. It refers to the range of microorganisms that an antibiotic covers. Tissue penetration refers to the reaching ability of the antibiotic to the site of infection. Antibiotic resistance is the bacterial resistance to the antimicrobial therapy, which can be either natural or acquired. This is the resistant potential of the selected antibiotics. High aminoglycosides such as gentamicin, tobramycin. The usual organisms which are resistant to each of the antibiotics are Pseudomonas aeruginosa. Preferred low resistance against amikacin and preferred low resistance against antibiotic. Alternative different classes low aflatoxin and others. Where possible, avoid antibiotics with serious or frequent side effects. The mode of elimination does not predispose to excretion or organ toxicity. Switching early from IV to oral is the single most important cost-saving strategy in hospital. The principles of antibiotic therapy should be borne in mind while doing antibiotic treatment, such as pharmacodynamics, the toxicity, the activity, the host resistance, the virulence, the colonization, and colonization resistance. There are four moments of antibiotic decision making, which is first is the make the diagnosis. Does my patient have any infection that require antibiotics? Second is empirical therapy and appropriate cultures. Have I ordered appropriate culture before starting antibiotics? Third is the narrow stop therapy. That is, a day or more has passed. Can I stop the antibiotics? Can I narrow it from broad to narrow? Can I narrow it from IV to oral? The duration therapy. What duration is needed for the patients? Difference in diagnosis that includes likely bacterial infections. All fevers are not infectious. Establish a rational and accurate differential diagnosis for the patient's current illness. Have a syndromic approach. Fever can be because of infectious or non-infectious. It can be bacterial, viral, and others. It can be in non-infectious. It can be inflammatory, hydrogenic, endocrine, others. Again, in the bacterial, it can be because of bacteremia, septic shock, organ disinfection, or and so there should be criteria for the proper selection of empirical antibiotics. Empirical, that is choosing without culture, knowing which bacteria or about its sensitivity. Now it depends upon establishing a rational and accurate differential diagnosis. Criteria for selecting the antibiotics should be that the antibiotic should be active against the pathogen. It should reach a sufficient concentration at a site of infection. It should have an appropriate narrow spectrum. Should be suited for the preferred route and should have the least toxicity. Should have the least cost. Now what do you suggest? IV or criteria for consider oral options are vital signs should be good, absence of malabsorption, oral intake should be possible, good bioavailability, and adequate antimicrobial concentration at the site of infection. Rule out how below the contraindication of oral infection, such as ongoing sepsis, necrosis, fasciitis, CNS infection, initial phase of staph aureus bacteremia, endovascular infections. Below slide shows us about the bioavailability of different antibiotics and routes such as IV and oral. The culture caveats are positive cultures without signs and symptoms is possible. So positive culture is not always an infection. Always focus on non-sterile cultures of GI, GU, and skin and wound swabs. Differentiate between the infection, contamination, and colonization. Ideally, antibiotics are not required. Good stewardship and infection control opportunities should be explored. The blood culture true pathogens which are not never contaminated includes gram-positive staph aureus, Streptococcus pyogenes, Streptococcus agalai, Streptococcus pneumoniae, Clostridium, and others. While in gram-negative, it is E. coli, Klebsiella, Pseudomonas, Acinetobacter, Neisseria, and Bacteroides. So do not forget to send the blood culture sensitivity. High, more than 50% pretest probability of bacterial scenarios such as vertebral osteomyelitis, epidural abscesses, acute septic joints, meningitis, and others. Negative cultures with signs and symptoms is possible. So think about the culture negative sepsis or infections. Prior antibiotic exposure has influence. Keep in mind some organisms never grow, such as Mycoplasma, Chlamydia, Trachoma, and others. Do not forget breakthrough infections such as Streptococcus multifida. Alternative investigations should be considered, such as radiology, histopathology, and patient with a bacterial infection treat only when therapy will alter the patient's clinical course. In terminally ill patients, antibiotics are not helpful. even in the presence of infection. So no significant changes in patient clinical status. With antibiotics or without antibiotics, similar overall outcome. Prolonged antibiotics. Think about the risk of MDR. Empirically target the microbes that cause the disease in differential diagnosis. Spectrum of antibiotics is very important for empirical therapy. Choose an antibiotic that likely causes the commonest pathogens. Avoid cover with the broad spectrum antibiotics that are unlikely to cause infection at a specific site. Antimicrobial choices for disease conditions differs for common pathogens and clinical conditions. Lower the threshold for empirical therapy, and it should be used in critical ill patients. First factors affect the breadth of empirical therapy by altering the likely microbial causes of infection. Consider patient immune status, broaden the empirical cover in immunocompromised patients, neutropenic patients, acute bacterial pathogens, and especially in mycosis. Patients with defects in the T cells such as atypical pathogen chronic fibrosis, pneumocystis carinii, cryptococcal meningitis, TB, as well as pneumococcal pneumonia. PKPD applications in critical ill needs to be considered for antibiotics like amoxicillin, ciprofloxacin, and others. Antibiotic volume or distribution in critical ills are also play a significant role. The volume or distribution changes in critical ill patients. Hence, the antibiotics volume or distribution needs to be drugs not delivered or reached at the site of infection if needs to be then hence administration needs to be for appropriate. Incorrect administration is associated with poor clinical outcomes. The route, the compatibility, the dilution details, the final concentration, and infusion times are key factors for successful therapy. Proper administration is mandatory for good clinical. So the antibiotic dosage depends upon the site of the infection, quality organisms, and type of formulation. Patient is dead, it does not matter if you have properly dose adjusted. Rightly said by my Ramesh. To have good dose adjustment. Beta lactams are the standard doses are derived from non-critical irritation. It means that beta lactams require frequent infusions, extended infusions, so that the concentration of the antibiotics is about MIC for most. First 48 hours of the critical period in adequate therapy during the first 48 hours of treatment increases the odds of. So practice de-escalation, it's been proved in numerous studies. It's a potential stewardship program. The practice should be based on clinical microbial biomarkers assessment. Then it is necessary to have a stop date. Risks that have been shown to be associated with the overuse of antibiotics serious. UTI is the most common indication for prolonged therapy. More than 75% of the treatment on UTI is prolonged. So there should be collateral sensitivity of antibiotic resistant microbes too. Understanding how evolution of resistance towards a given antibiotic influences susceptibility is a challenge. The longer the opportunity bacteria are exposed to antibiotics, the greater the pressure to select for antibiotic resistance. Shorter duration equals benefit as longer duration. So it's supported by number of studies. For each day of additional exposure, the risk of resistance increases by 8%. Sharing here in an article on antibiotic stewardship alerts. If antibiotic is not discontinued or stopped, it is not assigned, the antibiotic alert should continue to fire. EMR automatically stop dispensing for antibiotics if prescription without stop date. So the stewardship program. The new antibiotic mantra is shorter is better. User of shortest therapy is therefore greatly preferable to longer course of therapy. As you can see from this chart, there is no significant difference between the outcomes in the when longer duration. The duration of 5 to 7 days is usually recommended, supported by studies. For children with pneumonia, there is no difference between 3 versus 5 days of antibiotics, and similarly, there are many such examples where shorter duration therapy. Oral is a new mantra. It is because it is very convenient. No IV line exposure, for side effects, no fluid overload, and costs. If the patient has not responded to the antibiotics within 24 to 48 hours, consider review before broadening the therapy, identify the source and control it. If the source is not, if the applicable source contains associated with highest mortality, regardless of antibiotic therapy. To distinguish new infection from failure of therapy, new infections are expected in hospital settings. It will start after resolving the previous infection, so it should be evaluated differently from patients who never respond to therapy. The complete re-evaluation of the patient for a new infection, including reculturing or re-imaging if necessary. Pharmacokinetics describe the relations between dose of the drug and the concentration of the body, while pharmacokinetics is the interaction between drug and the body. The antibody dosing should be considered the constant dependent antibodies and the time dependent antibodies. Your time dependent antibodies are the beta lactam antibodies and constant dependent antibodies are like the aminoglycosides. Along with the host factor, the pharmacodynamic properties of the antimicrobial agents may also be important in establishing the dosing regimen. Similarly, this relates to concept of time-dependent versus concentrate-dependent killing. The drugs like time-dependent activity have slower bactericidal action. They don't have post-antibiotic effect. So their concentration is important. The data exists for the longer duration of the dosing interval. In contrast, constant-dependent antibiotics like aminoglycosides have higher post-antibiotic effect. Hence, the peak concentration is important. Then back to if you see the infection, bactericidal and bactericidal antibiotics inhibit at the same rate and should not be a factor in antibiotic selection. Monotherapy is preferred to combinations, and advantages of oral routes have been already been. To consider the bioavailability while selection of the antibiotics, we have excellent bioavailability the group of drugs, then good and antibiotic therapy for serious systemic infections should consider oral administration unless the patient is very critically ill. If the patient is not able to absorb oral antibiotics, there should be no difference in the clinical outcome using IV route too. Outpatient or parenteral antibiotic therapy has been used to treat infections on IV on outpatient basis. So preferred outpatient antibiotics are those with fewer adverse effects and had a longer serum half-life. Let's consider about therapeutic documenting. Therapeutic documenting is the measurement of drugs in biological fluids and ensures a high probability of therapeutic success. The drug factors must have large variability between subjects, small therapeutic index, and established concentration effects such as toxicity or relationship, therapeutic response that is not obvious. And these are the criteria for using therapeutic drug monitoring. Patient factors include suspected drug interactions, suspected drug adverse effects, suspected drug abuse. Pathogen factors are it should be a multi-drug resistant organism. So therapeutic index includes the ratio between the toxic dose and the therapeutic dose, and it is used as a measure of the relative safety of the drug for a particular treatment. Failures, the most common causes microbiology factors are because of colonization or colonization or contamination or in vitro susceptibility not effective. Antibiotic factors include inadequate spectrum, inadequate tissue levels, decreased activity. Antibiotic penetration factors include the undrained or inadequate abscesses, device-associated infections. Non-infectious disease causes include the disorders mimicking infections such as SLE and malignancies and others. So, infection needs to consider the various factors like contamination, colonization, and infection while doing the therapy. Colonization of versus infection, the principle is treat infection, not colonization. Provide empirical coverage, prevent direct the possible pathogen causing the infection. Avoid covering the multiple organisms. Treat the infection and not the colonization. Have a consideration of narrow spectrum of therapy preferred as compared to broad spectrum therapy. The best way to control the resistance is selectively restricting the formulary. Restrict only to the high resistance and potential antibiotics. Treat for the shorter duration of therapy that is effective in eliminating the infection. Whenever possible, treat with oral therapy instead of IV therapy. Preferably use monotherapy whenever possible. De-escalation is problematic if based on microbiological data alone. So de-escalation can be harmful if microbiological misleading. So it needs to be judiciously followed and implemented. C. difficile infections should be considered preferentially select antibiotics with lower C. difficile potential. Predisposing factors to C. difficile include clindamycin, beta lactams, and others. Thank you.